participants.
Okay.
Members are joining the meeting.
Can we find out from Hospital Ampang? Are they okay? Do we have any response from Hospital Ampang?
Oh, hi, Prof. Sorry. Yes, a bit of technical. Yes, we are ready.
Okay. So, so welcome everybody to today's this month's digital morphology session. It will be hosted by Hospital Ampang this round. They will be presenting two interesting cases for discussion. So, please, Hospital Ampang side.
Okay, can you see our presentation, Prof?
Yes, now can be seen.
Okay, all right. So we're going to start with the first presentation. It's going to be done by Dr. Nur Hafizatul Aida.
Okay.
Hello, Prof. Good evening, everybody.
Yeah.
I'm Nur Hafizatul Aida, binti American Hematology. I'm going to present the first case. 47 years old Indian lady, case of rectal adenocarcinoma, diagnosed in 2015, and hospital and had a low anterior resection and subsequently adjuvant chemotherapy post-op. And she was
your slide is not moving.
Not moving.
Okay. Next one. Yep.
Can see?
Can see now.
Moving? Is it moving?
I know that you are doing it full presentation, but what we are seeing are just it's okay lah. I think it's all right lah. Yeah, you carry on. But I think you may need to move manually your slide. Yeah.
Okay, wait.
Again.
And show. Let me try and see if we share entire screen.
I think kita kena put.
Okay, and then
slideshow terus kot Dr. Mina.
Okay, how about this?
Yes, we can now see. Yep.
Is it moving?
Yes, it's moving. Yes.
All right, good.
Good. Thank you.
Okay, I present again. 47 years old, was diagnosed to have rectal adenocarcinoma under hospital Temerloh back in 2015. She had a low anterior section and subsequently adjuvant chemotherapy post-op under HKL for 1 year and then subsequently defaulted follow-up due to logistic issue. And this year in May 2023, she was admitted to Hospital Bentung with fever and abdominal pain and was treated as intra-abdominal sepsis, colitis, was treated with antibiotic. An ultrasound was done as hepatosplenomegaly, no intra-abdominal collection. At that point of time, was noted to have hyperchromic nephrocytic anemia requiring 2 pine PET cell transfusion. And one day after discharge from Hospital Bentung, she then presented to PPUM with abdominal pain, 3S, perforated diverticulitis, colitis, with differential diagnosis of tumor recurrence. However, CA was not raised. CT abdomen was done, abdomen and pelvic was done. It shows enlarged intra-abdominal pelvic retrocrural nodes with inflammatory changes and hepatosplenomegaly. There's also a bivessel collapse lung consolidation with atelectatic changes, and she was then treated with antibiotic and was planned for colonoscopy. However, patient defaulted. And she was landed in surgical ward Hospital Ampang with lethargy, and at that point of time have complaint of right neck swelling, and excision biopsy was done. And further questioning, she claimed that she had a colonoscopy done in private and the finding was normal. This is the HPE of bilateral cervical lymph nodes that show a diffuse infiltrate of large lymphoid cell, which shows a scattered, as you can see, the cell in the red circle It's a hallmark cell with characterized by kidney shaped nuclei with multilobated nuclei, marked nuclear hyperchromasia, while in the cell in the blue circle show mitotic figure without risk. It shows the cell shows negative for B markers and positive for CD30, diffusely positive, and also positive for cytotoxic marker DIA1 and granzyme B. Also, the cell also showed negative for epithelial marker and as well as TDT. And the cell showed aberrant T cell expression with positive CD2, while negative for CD3 and CD5 as well as CD7. It also showed positive CD43, and the Chi-7 show proliferative index of 70%. Hence, the interpretation was anaplastic large cell lymphoma. And then she landed to us with right neck swelling, and at that point, there is a cervical lymph nodes, hepatosplenomegaly, and the counts at that junction, anemia with HB 7.4, platelet was normal, and leukocytosis LDH was elevated. I think Talina will present for the FBP and marrow.
Hi, Prof. Chong. Alina here.
Yes, thank you.
Can you hear me?
Ken?
We've actually taken the suspense out of the case. I sort of given you the answer to it, but I think this case and also the next case highlights difficulty in diagnosing lymphomas with large cells when the infiltration pattern is very unclear just based on H&E. So we'll illustrate this point in both of these two cases. So I'll start off with.
So when you all receive the specimen for bone marrow, you have no knowledge of the lymph node yet, lah?
We did actually, but as I will show you in these next few slides, it is quite difficult to identify these cells in the bone marrow aspirate and in the bone marrow trephine just on H&E. So we have to, at the end of the day, rely on our IHC to confirm the diagnosis. Based on just the morphology, it's a very difficult call to make. So these two cases will illustrate this point. I'll show you the first case, which is, so she has a positive lymph node biopsy of an ALK positive ALCL, and this marrow was done to rule out marrow infiltration, or it was basically a staging marrow.
Okay.
So this is the full blood picture, and here the counts of the hemoglobin was 8.3, normochromic, but slightly microcytic. No, sorry, MCV. So he was normocytic but slightly hypochromic on the counts, yeah. And platelet count was 132. And with a white cell count of 9.39. So you can see the background of moderate anemia. And I think also maybe appreciate that there is the morphology clear, Prof?
Low power, yes.
How about now? Is it okay?
You can see, but cannot see the white cell detail.
Okay.
Or rather, yeah, because low power.
Yeah.
Is there any suggestion of a leukoerythroblastic change?
Yes, there was indeed.
Oh, okay.
So there was some myelocytes. See if I can find them now.
Yeah, not spherocytic, the red cells.
Was she transfused?
Yeah,
It does look a little bit dimorphic.
Oh, okay.
Yeah.
More like store blood experience.
Yeah, it's more like a red cell storage changes rather than actual spherocytes. So there's a myelocyte there.
Yep.
Oh, there. So there is actually quite left shifted because you can see there's a band form here.
Yeah.
Can't seem to find the NRBC, but it was reported to have leukoerythroblastic picture.
Okay. Yeah, probably not very easily seen lah.
Yeah. Yeah, it's so lame, but as a hematopathologist, every time I see a myelocyte and an NRBC in the same field, I get very excited. Oh
Yeah,
wow.
not easy to find one.
But in reality, that's something that we hardly get. Yeah, okay. I'll move on to the aspirate.
No suspicious cells in the peripheral blood.
No, there was no suspicious cells to be seen. No abnormal lymphoid cells, no blastic looking cells, just a mild or moderate anemia with a leukoerythroblastic picture. And now looking at the bone marrow, actually, just to remind you, this is a 47-year-old female. So the bone marrow is actually hypercellular for age.
Yeah, agree. Yep.
Yep. So, and just under low power, we can appreciate that the cellularity of the cell trails are also quite hypercellular.
Yeah, agree.
So zooming in a little closer, just with a glance, there seems to be a very reactive, it seems to be a very reactive marrow. Is it clear, Prof? Can you appreciate the granulocytic hyperplasia, or is it too dark?
It's too dark. Yeah,
It's too dark.
it's too dark.
Can we...
Unless you get some light, some more lighting through.
Exposure ke? Exposure dia ke? So you can't appreciate the nuclear features, kan, Prof? It's too dark, yeah?
Yeah, it's too dark. Yeah, it's too dark. Maybe the area is too thick.
A very thin area already. Huh?
Already thin, huh?
Definitely the in front of the trail.
Okay. Can see better lah.
Can see better. Okay.
Yeah.
Okay, that's better. Okay, so generally there was a sort of a slight granulocytic hyperplasia. It was predominantly granulocytes. But occasionally we saw some, I don't have a, can you just hover? You see there's very dark blue, large.
There are some large mononuclear cells.
Yeah, with very dark blue cytoplasm, which we couldn't tell whether they were proerythroblasts or cells in question. Okay, hold on. There was some of them appeared quite vacuolated. Let's see if I try to see whether I can find them. But as you can see, as we scan through the marrow, they're not many of them. The predominant cells are your granulocytes and a bit of erythroid. But the cells in question, these abnormal lymphocytes, tak ada. Okay, here we see two of them. Okay,
Vacuole.
very large, very basophilic cytoplasm, vacuolated, and not resembling anything normal.
Definitely don't think it's normal. The
Yeah.
two cells there, vacuolated cell, are not normal. Yeah.
So as we scan the slide, you'll see that there aren't many of these cells. Or at least you can't discern or differentiate between the normal cells and the abnormal ones. Okay, there's one more here.
Yeah. Yeah, definitely doesn't look normal. It's not a megakaryocyte though.
It's not a megakaryocyte, precisely. There's one more here. But it's very scattered, yeah, Prof? I think you all appreciate that it's all over the place, but not in abundance, and it's not a diffuse sort of infiltration.
Agreed, yeah.
But the background is highly reactive, lots of
Granulocytic cells.
granulocytic cells, yeah.
Not much of the nucleated component.
Yeah.
Or rather, the nucleated red cells are not that much. The erythropoiesis seems to be very much suppressed. Yeah.
And there's also a little bit of hemophagocytosis going on.
Oh, yeah, a little bit, yeah.
Yeah, okay. And then here, a binucleated one.
Oh, yes, a binucleated one. Wow. Looks like Hodgkin's, huh?
Yeah.
But it doesn't have the Hodgkin's features.
Okay. Okay, so I will now show you what it looks like on the Trefine. So again, for age, this is a hypercellular marrow for age with a cellularity of perhaps 70, 80%.
A bit starry sky.
Yeah. But when we go closer, there are actually megakaryocytes. And some of them are the nucleated, some giant cells, but mainly they are megakaryocytes. But we can't tell whether you see, some of them look like nucleated cells, nucleated giant cells. Some of them are megakaryocytes.
Yeah, there's increased number of megakaryocytes. Yet your platelet count is normal.
Yeah.
Show how dysplastic this mega, not able to mature properly.
Okay, but what I do want you to appreciate is that if we look at the topography of the marrow, it's very much altered. And I want you to just look in the middle of the screen. You'll see presence of some abnormal looking, highly hyperchromatic cells with multiple nucleoli.
Yeah, definitely, yes.
Yep. Some of them kidney shaped, some of them with round with multiple nucleolus, and they are sort of like scattered in between normal cells.
Yeah.
They're not forming any nodules, not forming any aggregates per se. They're just sort of singly distributed, scattering within the other hematological elements. So if we were not convinced in the bone marrow aspirate, we definitely convinced after we see the HNE lah. Something is happening, something sinister is going on, but we have to confirm using the IHC.
Yeah. From the HNE point of view, it looks like there's a not only there's a paratrabecular infiltrate, but also got intertrabecular infiltrate.
Yeah, definitely.
Mm.
Yeah.
And it's very
They're
pleomorphic.
very much interstitial in its distribution. Yeah, that one. Yeah. So they all have the same features. They're quite large, very open chromatin pattern with multiple nucleolus, and some of them with kidney shape.
Mm.
So because we knew that the patient had a ALK positive lymph node,
You think there's eosinophilic infiltrate or not? You think the eosinophil are quite prominent, or am I mistaken?
no, I think you're right, Prof. And I think in some of the literatures say that these hallmark cells can also be quite eosinophilic. So some of them may be true eosinophils, and some of them could actually be the neoplastic cells, because they can have quite, in the books, they describe them as having eosinophilic cytoplasm. But these are eosinophils lah. But some of them...
No, I was thinking because of the, there are a lot of other cells around. You see a lot of lymphoid cells, you've got eosinophil. So this give like a background like Hodgkin's,
Yeah, very inflammatory background.
Yeah.
Yep. Yep. I think if we didn't have a positive lymph node, then we would definitely, Hodgkin's would have definitely be one of the main differentials.
Yeah.
Because it has a very similar pattern,
Right.
Scattering of large neoplastic cells with a background of very inflammatory lymphocytes, histiocytes, eosinophils.
Yep, correct. Yep, definitely. Yep.
So I'll show you the first IHC. So just like Hodgkin's, ALK positive ALCL will also be CD30 positive. So
Very interstitial. This one is CD30, yeah?
CD30, yeah.
Okay.
Yeah. I just want to zoom in a little bit. So in the literature, these cells are described as being kidney shape and horseshoe shape, but it's not as apparent here. But it does match the HNE lah, where we see very scattered, lots of cells, but they're not forming any nodules, they're not forming any aggregates, they're sort of like just singly distributed. And if they do tend to cluster, it would be around blood vessels, as you can see in this one. Otherwise, they are just sort of like singly distributed.
Yeah.
If they do cluster, it's around blood vessels like this one, yeah? There's a blood vessel in the middle, and you see a clustering of these cells.
Yeah. Earlier on, I thought it's paratrabecular also, but it doesn't look like after CD30 staining. It's more like intertrabecular distribution.
Yeah. Or interstitial, yeah, Prof?
Interstitial infiltration, yeah. More like
Yeah.
interstitial picture.
Okay. So this is CD30. So they're also, they are ALK positive ALCLs are T cell in origin, but often they lose the CD3 marker, and they can be positive for CD2 or CD5, but often CD3 is negative.
Mm.
I'll show you the ALK stain. So
What
this
was
is
the trephine stain for CD15?
CD15.
Oh,
Yes, it was, bro.
So, okay.
So the problem with CD15 in the bone marrow is that it also highlights your granulocytes. So it's
Yeah, it might make it more difficult.
quite difficult to differentiate, especially if your neoplastic cells are so scattered.
Yeah. Mm.
In Hodgkin's and in ALCL, your CD15 is said to be less bright than your granulocytes. So it's hard to appreciate, but you can see some of the larger cells with, but it's hard to say.
Yeah,
But
it's really hard.
CD15 is supposed to be negative in your ALK positive ALCLs. So it's really quite difficult to say here, because there isn't one single nodule that we can sort of map against the CD15. They're just sort of everywhere. Yeah. So this wasn't a helpful marker, lah, Prof.
Yeah, in this case, it's difficult. Difficult for interpretation.
So in cases where the neoplastic cells are so scattered, the only helpful markers will be the very specific markers, the markers that will only highlight the neoplastic cells and nothing else.
Yeah.
So CD30 being one of them, this one is the ALK stain itself. So here,
This one is the ALK stain.
correct, Prof.
Oh, okay. It does look like it corresponds to the CD30. Yeah.
Yeah, indeed. So you see these multinucleated cells.
Yes.
Very large looking neoplastic cells. The pattern fits, they are scattered, not forming any clusters. They're not staining the smaller cells, they're only staining the darker cells.
But interesting is that this neoplastic cell, which stains strongly, actually are very variable in sizes.
Yeah, betul.
Some are very big, but some of them just medium size.
Yeah, that's true. And ALCL, if you read WHO, they say that it has a very varied morphological presentation. You can have very small cells, you can have predominantly all of them large cells, but this seems to be a good mixture of both small and large.
Yeah.
And even the ALK stain, depending on what the translocation is, who the ALK gene translocates with, it'll give a different pattern of staining. So some will give you just a cytoplasmic stain, some will give you a nucleus plus cytoplasm plus membrane stain. Some of it will just give a membranous staining. So it depends on which gene the translocation has occurred with. So here, predominantly, I feel like it's highlighting your membrane quite strongly. But we'd have to do a FISH or a cytogenetic studies to confirm what sort of translocations occurring here, lah. But at the end of the day, it does show a positive stain, which is good enough.
Even the stain also, the expression of the ALK translocation, the resultant fusion protein is probably variable in the expression also. Look at the way that it's stained, yeah, in the cytoplasm. You think it's a predominant surface? I think it's more like cytoplasm.
Yeah. Yeah, some of them have a dark membrane stain.
Mm.
And then there's also like a weaker cytoplasmic expression.
Okay, so highly variable it looks like, yeah.
Okay. So just to show that that it's lost its CD3 expression, we also did a CD3, and here your CD3 is picking up your smaller T cells.
Mm.
And if you look in the background, the larger cells are not positive for CD3.
Yeah.
The ones with the multiple nucleolus, the larger ones, they are not picking up the CD3. So it is in keeping with the loss of expression of CD3, which is seen in most cases of ALCL.
This one is cytoplasmic CD3, yeah?
Yeah.
Mm. Yeah. Okay, negative for the tumor cells.
And then the other stains that we did was EMA, which was said to be positive in the lymph node biopsy, and we also found the same, but it didn't. We felt like it didn't pick up every large cell.
Yeah.
So it was a partial expression. Some cells were positive, but some cells were negative, as highlighted by these two cells in the middle here.
Yeah. One don't stain, the other one is quite strong.
Yeah.
Interesting, yeah.
So partial expression of EMA. But combining all these together, this was consistent with a infiltration by ALK positive ALCL, Prof.
Okay, I think it's yeah.
Okay.
You convincingly put up that case lah. It is ALCL.
Yeah, it was helpful that he already had a positive lymph node lah.
So I'll pass it back whether it's a Hodgkin's or not.
Yeah, I'll pass it back to Ida to continue.
Okay, thank you.
She had a CT thorax and abdomen, which showed a nodule in lungs, but it's quite tiny, and multiple enlarged mediastinum nodes, which cause compression and narrowing of the trachea as well. And she also has hepatomegaly and splenomegaly with heterogeneous enhancements in the arterial phase scan, as you can see in the picture.
How come clinically they didn't feel it? Huh?
It is dull throat space for the skin and can palpate the enlarged liver.
Because normal spleen is not more than 10 cm. So by the time it's 16.5, it should be below the costal margin. It should be palpable.
She was treated with CHOP 21 for 6 cycles, recently completed on the 9th of January 2024. And we plan to repeat EOT end of treatment bone marrow on 8th of February 2024. A little bit about anaplastic large cell lymphoma. It's a group of mature T cell non-Hodgkin lymphoma with significant overlap in pathologic characteristic but variable genetic and clinical features. All subtypes contain at least some cells with reniform or horseshoe-shaped nuclei and prominent Golgi zone, which is characterized of hallmark cells that show strong uniform CD30 expression, as you can see in the picture and what we discussed previously. According to WHO 2016, ALCL divided into 4 types: ALK positive ALCL, ALK negative ALCL, primary cutaneous ALCL, and breast implant associated ALCL. is further divided into systemic and localized ALCL. ALK positive ALCL and ALK negative under systemic, and it is an aggressive lymphoma that commonly present with lymphadenopathy, advanced disease, and these symptoms, which involve extranodal site as well, such as skin, bone, soft tissue, common, more so in ALK positive than ALK negative. And in ALK positive, usually affect children and young adult, while in ALK negative, more older person. While in localized ALCL, it's divided into primary cutaneous and breast implant associated ALCL, which is good prognosis. As the name implies, is the primary cutaneous involve single or multiple skin lesion. And the breast, of course, as the name is associated with breast implant as a peri-implant effusion or infiltration, typically seen in adult. The hallmark of ALK positive ALCL seen in the HNE and give ALK positive, express ALK positive, of course, and CD30 as well as EMA. For the ALK negative, ALK markers negative, while CD30 positive and EMA also negative. For the treatment of ALK positive ALCL, the outcome with CHOP or CHOP-like regime are generally favorable, with exception with patients which have multiple IPI risk factor. And considering patients of all age, the outcome of ALK negative ALCL consistently worse when using CHOP-like regime than ALK positive. For the novel therapies in systemic ALCL, for basically in a relapse setting, anti-CD30 can be used, which is brentuximab. It's mostly widely studied in agent in ALCL. Crizotinib is an oral ALK inhibitor explored in ALK positive. The data is limited in adult patient. I think that's all. Thank you.
Yeah, thank you very much. So the question now is a clear-cut case now after the immunohistochemical studies that this is a ALK positive ALCL, anaplastic large cell lymphoma. So the question is, what could be the cause of it? Is it because is it related to the original colonic CA, or is it related to the treatment that was given? Any discussion on this one?
I personally, it should be, to the best of our knowledge, basically it is not associated. It's not a tumor or a treatment associated presentation. I think it's probably just a separate entity, but that is something that we are not very familiar with lah. Usually our patients who have had chemotherapy before either present with MDS or an AML, and not usually a lymphoma. Yeah, so it is not a common association. But I suppose anything in medicine is possible, right? So
yeah, trying to look for a connection if there's a connection.
Yeah.
Especially if there's a genetic marker or something like that, but it doesn't look like it here.
Correct. It doesn't look like it here. Not to the best of our knowledge.
Yeah. Okay, this is considered not a common tumor, isn't it?
Yeah.
It's quite a rare occurrence. Wonder whether anybody among the participants, anybody have seen such a case?
No, this is the next.
No. All right.
Not this. Oh, okay.
Okay, so if there's no comment on this one.